This some of the simple things I have picked up to discuss, because even today I find somebody was spontaneous patient, somebody was holding the mask, but there was no cap, no wave. So I said, "What is your cap now?" Because the jaw thrust maneuver was not adequate. So you see the picture, and just to uh, show the importance of this basic maneuvers. This is you can do it when there is even cervical spine injury. This is the head tilt and chin lift maneuver. This is the two hand, but this is not recommended for cervical spine injury. This is how the oral airway is being placed. You see in this picture that the proper size is important, because if it is short, the tongue will fall and give obstruction. If it is long, it will touch the epiglottis and patient will be buckling. This is the nasopharyngeal airway, what I call. Look at the length measured from nares to tragus, and it goes over the floor of the mouth, not like this direction. It is over the roof of the hard palate kind of thing. This is how the mask is being held with one hand. It's important to pre-oxygenate that you hold the mask properly. So this is one hand technique. 3 fingers are used to lift the mandible and 2 fingers to hold the mask in both sided view. And this is a 2-hand picture, but the A and B are 2 different techniques. In B, it is more forceful with hypothenor. You are pressing with the cheek of the patient, the mask, and with the other fingers, you are lifting the mandible. So this is more effective than A type. About the airway management, the choice, so mask ventilation during pre-oxygenation, you have to, but as such, for short procedures, mask ventilation is seldom used nowadays. Technically challenging, mask misfit, and handling difficulty, especially in obese patient, bearded patient, obstruction from large tongue and oropharyngeal tissue. To improve oxygenation, we can give some pressure support, 10 to 15 centimeter of water by semi-closing the APL during pre-oxygenation. That will help improve. Intubation and supraglottic airway or LMA likely to require controlled ventilation to prevent hyperventilation, and supraglottic airway may not give a seal. So sometimes for normal patient, we are using LMSA for lap call or something, but for obese patient, we'll go for controlled ventilation and intubation. Pressure support mode is with ProSeal LMA, we have used pressure support mode to improve ventilation. But for patients who are more than BMI more than 40 and primarily abdominal obesity and major abdominal and thoracic surgery is proposed, and surgery lasting for more than 2 hours, and patient will go for head down position. So definitely controlled ventilation with endotracheal tube is recommended. These are some of the disease states that may be associated with the difficult airway management. These are, I'll not repeat, Pierre Robin, Teacher Collins, and macropnetia, Down syndrome, especially adult with Down syndrome. And acquired is morbid obesity, infections of the airway like Ludex angina, epiglottitis, retropharyngeal or intraoral abscesses, ankylosing or rheumatoid arthritis, OSA, tumors involving the airway, trauma, a burn of face, head, and neck, and radiation of the face and these are the conditions that increase the risk of aspiration during induction of anesthesia. Definitely, if not properly fasted, emergency surgery or trauma. In trauma, one thing I want to mention that if a patient, say, goes out of home after having lunch, say after 1 hour having trauma or head injury, the stomach stops emptying, and then coming to hospital maybe after 10 hours, but stomach is not empty. That you have to know that. Pregnancy after 12 to 20 weeks of gestation, there was a suggestion that with gestational age, increased risk is there. It is not correlated. Symptomatic gastroesophageal reflux disease, diabetes, or other reasons of gastroparesis, hiatal hernia, gastric outlet obstruction, esophageal pathology. Hiatal hernia is common in obese patients. There may be some bowel obstruction, increased intra-abdominal pressure, maybe from ascites or huge abdominal mass. These are the situations where difficult mass ventilation can be difficult, like older age, 18 plus patient, male gender, obesity more than 26 BMI, facial hair, beards, malampathy 3-4, inability to protrude, mandibular protrusion, thyromental distance short, snoring, abnormal neck anatomy. These are difficulties for supraglottic airway placement, even like male gender, BMI more than 30, poor dentition or large incisors, neck radiation history, reduced mouth opening, reduced cervical spine motion, tonsillar hypertrophy, big tonsils. Fatty patients may have big tonsils also, glottic, hypopharyngeal, and subglottic pathology. The more the factors, more difficult it will be. These are the difficult situation for endotracheal intubation by direct laryngoscopy. If the patient has a prior history of difficult intubation, interincisor distance is less than 4 cm, thyromental distance 6 cm, less than sternomental distance 12, etc. Malampathy 3-4, mandibular protrusion inverted prognate, neck circumference more than 40. Especially sternomental distance and mandibular protrusion and neck circumference and submental compliance. These are risk factors for video laryngoscopy also. So these are difficult video laryngoscopy conditions like otolaryngologic surgery. I don't know why they've included cardiac surgery. Maybe cardiac surgery draping is there, so draping may be a difficulty in video laryngoscopy. Sniffing, head position unable to do, abnormal neck anatomy, neck scar, neck mass, neck radiation, decreased cervical spine motion, decreased oral entry like obesity, decreased mouth opening, decreased mandibular movement, restricted oropharyngeal spaces like edema, bleeding, and retrognathia, and some. To deal with these difficulties, we should have a difficult airway cart. That will contain a different assorted blades and video laryngoscope and assorted sizes of tube and other ancillary things like tube changer, stylus, light vents, and Magel's forceps and other forceps, supraglottic airways, intubating LMS and LMS, different sizes, other non-invasive airway ventilation devices, ultimate flexible fiber optic intubation equipment, and availability of suitable emergency invasive airway access. What I mean, cracothyrotomy or tracheostomy if necessary. And axial carbon dioxide detector. So those who have capnography is probably excused. This is about American Difficult Airway Society. So what we have to think ahead, that whether it will be a difficulty to do mask ventilation, or difficult for supraglottic airway, or difficult laryngoscopy, or maybe difficult intubation, or even difficult surgical airway access. Sometimes the patient may not be cooperative, or patient may not give consent even. So the things to consider is whether to do AWAC intubation or intubation after induction, and whether to do non-invasive technique or invasive technique for the initial approach to intubation, and video restrict laryngoscopy as the initial approach to intubation. Preservation versus ablation of spontaneous ventilation. So what practically we do after induction, before giving muscle relaxant, we many times we do video laryngoscopy to evaluate last minute evaluation of the airway. And if we found that it is possible to intubate, it will be easier to intubate, then we go for longer acting muscle relaxant as we practice. And we have standby other mechanism. So that from there, the continuation is either do AWAC intubation or intubation after induction. If initial attempt successful, no problem. If it's failed, then we need to call for help. Then face mask ventilation. If face mask ventilation is adequate, then we can go for supraglottic airway. Or if supraglottic airway also fails, then emergency pathway should be activated, like that. This is the common thing, but just to recapitulate, the final airway assessment is by a direct bronchoscopic assessment, or assessment, so that we can be assured that there is no structural abnormality, and there is no cyst or something. The other day it happened, there was a vallicular cyst here, and as soon as we gave muscle relaxant, it dropped down to obstruct the whole thing. This is Cormac Lehan grading of the laryngoscopy, so everybody knows it. This is the ultimate video laryngoscope. It's a storage product. Here I will show you video laryngoscopy. Things has become so easier, but you see the posterior wall of the pharynx is so fatty and flabby that when it collapses, it almost obstructs the airway.